is Sherrod. I'm a nurse practitioner at High Risk Obstetric Consultants, and today I'm going to talk to you about pre-existing diabetes and its effect it has on pregnancy. So the information that we're going to want to gather when we come together is a lot of health information for you. We're going to want to know how old you are, how many pregnancies you've had, how long you've had type 2 diabetes, who manages your care outside of pregnancy. We're going to know what kind of meter you have and how often you're checking your blood sugars. Sometimes outside of pregnancy, you'll be checking a lot less than what we're going to want you to check inside of pregnancy. Depending on your type of diabetes, we'll talk about specific timings of checks once you get here. How often you're injecting insulin, if you're injecting insulin. We're also going to want to know what kind of pump you have, if that's part of your regimen, as well as when your last A1C was and who drew that. We'll also want to know things like, when did you have your last dilated eye exam? Have you ever completed a 24-hour urine collection? Those things are important so we kind of know what is happening with your diabetes. The eye exam, diabetic retinopathy, doesn't develop because of pregnancy, but it can worsen during pregnancy. So we want you to have someone who you're seeing who may see you once during the pregnancy, or they may follow up and see you regularly. As far as kidney function, your kidneys have to filter this much blood volume, which is a very small cup before pregnancy, but during pregnancy they have to work harder and they have to filter more blood volume. Your kidneys are kind of like a colander and protein is like a macaroni. It really shouldn't fill or spit, it shouldn't go through, spill through, but it will, and so we want to know what kind of protein leakage you have so that we know, are you at increased risks for complications with the pregnancy, including growth restriction or blood pressure issues, and we'll talk about that a little bit more. We're going to have to evaluate your heart. Most of our patients will at least have an EKG done. Some will even have a maternal echo, depending on how long you've had your diabetes and other complications. We want to know if you have any neuropathy in your hands or feet. Have you ever been hospitalized for diabetes? And do you have episodes of low blood sugar? So we'll kind of gather all that information, kind of knowing where we need to start with the other testing. And then we'll also look at your past medical history. What other things do you have besides diabetes? Hopefully only diabetes, but some people have other issues as well. We'll look at your past surgical history, social history, which is, just are you married? Who do you live with? Those kind of things, so we can see how life is for you. Do you work outside the home? Do you not? We'll talk about your immunization history, and then we'll decide if we need to get further immunizations during the pregnancy. We generally recommend a flu vaccine for all of our pregnant patients who have diabetes. We also recommend COVID vaccines and boosters. You'll also need to have your Tdap for the pregnancy. We look at your family history, who else has diabetes in your family, heart disease, things like that. We'll talk to you a little bit about your partner and any drug allergies you may have. Then we'll go through and look at your medication list. How does that affect the pregnancy? Do we need to add medicines? Do we need to take medicines away? Are there some you can continue or some maybe we shouldn't? And we'll talk to the physician about that. We'll look at pump settings if you're using a insulin pump, and we'll adjust those. If we're using injections, we'll adjust those as well, especially if you bring a log to your first visit. We'll look at your OB history. How did the pre-existing diabetes complicate any previous pregnancies? What's happening there? GYN history and genetic history. We will ask you genetic questions, and if you have a need for a genetic counselor, we'll make that appointment as a follow-up with our appointment in a future visit. Then we'll do a review of systems and a physical assessment of you when you're here in the office. So we'll listen to your heart and lungs, look in your eyes, look in your ears. We are avoiding this area at this point due to COVID, but that may change in the future. We'll do a foot exam if you haven't had one in the last year, and then we'll kind of see how that is. Then at this point, I'm going to look at your blood sugars, and we'll make adjustments kind of to whatever we need to. If we don't have a log, then we'll give you information on how to keep a log, how you can keep it if you're a type 2 or a type 1 when you need to check, and we'll give you written information about that. And then we'll talk a little bit about education. So with diabetes and pregnancy, the complications to the baby are similar to that of gestational diabetes. The babies can get very big, so babies can get macrosomic, and we will measure the baby, or your primary OB will measure the baby regularly in the third trimester to kind of see growth. So we're measuring head, abdomen, to kind of compare that growth. We want babies to grow at a normal rate. When exposed to high blood sugars, babies put on weight in their tummy. We can measure tummies. We don't measure shoulders, but we correlate the stomach measurement with the shoulder measurement. So we want the head and the stomach to be somewhat symmetrical, or the head to be bigger, because that, if it's not, it increases your risk for C-section or shoulder dystocia. So we want to make sure that our baby is a nice, normally grown baby. Also, we know if babies get very large, they have increased workload on their heart or liver. That resolves after delivery, but we definitely want the baby to enter the world in the best condition that we can have. Second thing is you can have too much amniotic fluid, because diabetics, when thirsty, when their blood sugars are high, they get thirsty. So they drink their amniotic fluid, and they can do that in excess. Babies will do that in excess and overproduce fluid, and they're kind of in a closed bubble. So they drink and pee and drink and pee. That can distend the uterus and increase the risk for early contractions. 3 things can happen after delivery with a baby. Jaundice. Babies have jaundice for lots of reasons, but diabetes increases that risk. So we'll just watch the baby for yellow of its eyes or skin. The baby can have low blood sugar after delivery. So hypoglycemia, so much so that the baby may need extra pokes on its feet, extra supplemental feedings, or even an IV with a NICU stay. So we don't want to do that. The best way to control that is to control the blood sugars going into delivery, so that the baby is making small amounts of insulin, because the fetal pancreas works. And so if we're exposing this baby to lots of high blood sugars, then the baby will be overproducing insulin, leading to that hypoglycemia. Because once they're born and the cord is cut, they can only take in small amounts of milk because their tummies are very small. Also, the babies can have trouble breathing. Respiratory distress can happen because the lungs are maturing in the 3rd trimester. The enzyme surfactant is released, which matures the lungs, makes them soft, stretchy, ready to breathe outside the womb. That's blocked by high insulin levels. So if we have a lot of extra high blood sugars, the lungs can get behind, and you can have a term baby that has some trouble breathing. So we want the baby to do as well as possible after delivery, so we want to control the blood sugars during delivery. With pre-existing diabetes, moms have lots more issues. We talked about having your overall A1C, or having an A1C drawn. If you don't have one recently, we'll draw one for you. But A1C is an overall blood sugar. So the glucose sticks to the red blood cell, and it gives us an average of what your blood sugar has been. It doesn't tell us exactly. The logs are a better idea of exactly how your blood sugars have been, but an A1C kind of tells us where we're at. A1Cs during pregnancy, we would like for them to be in the 6% or lower range. Anything above that, 7 is kind of a moderate risk, but 8, 9, 10, 11, 12, 13 increases the risk that your baby could be born with birth defects, or we could have a miscarriage in the 1st trimester. So we want to make sure that we are getting the blood sugars controlled as quickly as possible so that the baby does well. The first period of time, even before a lot of people know they're pregnant, is when the organs start to form for the baby. And so that's why it's important, if we're going to get pregnant, that we have a good A1C going into attempts of pregnancy. So we like to see you preconception if possible. If not, we want to see you as soon into the pregnancy as we can, so that we can fix the blood sugar so that the baby will develop normally. The baby's organs start forming at about 5 weeks. So you have central nervous system, heart, arms, eyes, legs, teeth, palate, external genitalia, and ears. Those things, along with multiple other things, can be affected if we have high blood sugars. High blood sugars can damage those organs. And you'll get an anatomy ultrasound either at your primary OB or with us that will look at those organ systems and hopefully make sure that everything looks normal between 18 and 20 weeks. For our pre-existing diabetics, we do fetal echoes on the baby's heart. If deemed necessary by the MFM, to make sure that the heart is also normal, because that is a place where a lot of defects can happen. The most major complications that can happen with pre-existing diabetes is fetal death. We can lose babies early in pregnancy due to miscarriage. We can also lose babies up to term because of diabetes. So you will have regular antenatal testing. That can begin weekly at 28 weeks to twice weekly at 32 weeks, depending on the situation and your blood sugar management overall. So we'll want to watch the baby very closely, do regular growth ultrasounds. You'll have ultrasounds as well as fetal monitoring sessions that will be done, and we'll schedule that either in our office or with your primary OB, or maybe in a conjunction with both, depending on how your visits are going. We also worry about vascular issues during the pregnancy because it can cause growth restriction in the baby. So with diabetes, you typically do worry about a big, large baby, but we also worry about very little skinny babies as well. So we'll want to watch the growth closely for both of those things. In our appointment, if you have not been injecting insulin before, we will talk about insulin management. I can show you how to use insulin pens or vials or syringes, whichever one we're going to use. We'll talk about how we like to use abdominal injection and regional rotation. We'll talk about hypoglycemia guidelines so that you know how to deal with that if you have low blood sugars. We'll talk about any other supplies you may need. If you're a type 1 diabetic, you may need glucagon emergency kits or ketone strips. So we'll talk about sick day management because DKA can occur much easier in pregnancy and a much lower threshold. So we'll be showing you what you need to be watching in case we were to have DKA during the pregnancy, which is worrisome for the baby and you, and we would need you to come into the hospital for that. So we'll talk about that. Lastly, we'll draw a lot of labs most likely when you're here. Depending on where you're getting your prenatal care, we may do your prenatal labs. We usually will look for vitamin D, vitamin B12. We'll usually assess your thyroid, and we'll assess your A1C if you haven't had one done recently. We'll also get a 24-hour urine unless you've completed it somewhere else. That's where you'll collect urine for 24 hours. We give you supplies here, and usually the day before your next appointment, you'll void in the morning and flush it, look at the time, and then from that point on, you'll collect every urine until the same time the next day. It's very important that you don't miss any urines for that collection and that you bring all your urine in. So if you get one of your containers pretty full, we'll talk to you about getting another container to clean out and bring. So you'll bring that in and go ahead and draw that 24-hour urine so that we can kind of see how much protein you have out. Do you have a diagnosis of nephropathy? If you did and it was significant enough, we may refer you to a nephrologist. So there's lots of other appointments that may happen from this appointment. Again, we'll assess, you'll schedule yourself an eye exam, we'll evaluate your heart, we're going to evaluate your kidneys, and we're going to watch that baby. After we get all these things done and I talk to you for a little while, I'll go talk to a maternal fetal medicine doctor, and we'll come together, and together we decide as a team what other tests we need. Do we need the echo with the EKG, or is the echo enough? Are we doing a fetal echo? Do we need to see any other referrals like genetics? I'll give you prescriptions for any medications we were to need, such as baby aspirin or strips, ketone strips. And then our dietitian will go over a diet with you, which will be another video you can watch, and she'll tell you how we would like for you to eat, because diet is ultimately a big way to manage diabetes, is following a specific carb diet and monitoring your blood sugars and taking the insulin if needed. We'll follow up usually in a week, and that time we'll assess baby if we need to, as well as you. Thank you.